Let me go in. Are you able to see that okay?
Yes.
Okay, perfect.
And my name is Smitha Joshi, and with me today is Stefani Wade. We both are speech language pathologists, and we both specialize in feeding, swallowing issues in children. We both work at Essential Therapies, and we are excited to be sharing what we know with all of you. So, Stephanie, do you want to get started?
So just a little overview of what we'll go through today. We're planning to leave time for questions at the end. So if you want to send in your questions to the chat or you want to ask at the end, those are highly encouraged. So we make sure that we are talking about the topics you want to talk about. But just a general overview, we're going to go over some factors and considerations of some medical conditions that we know to be associated with ASXL syndromes. We'll talk about your multidisciplinary team and our specific role as SLPs on that team and what that looks like for feeding assessment and intervention. We'll go into a little overview of feeding assessment intervention, and then we'll talk about some psychosocial factors to consider when we're thinking about feeding and swallowing in the grand scheme of our lives and not just in a therapeutic setting.
So we're going to talk about the communication and feeding challenges. And what we have done on this slide is the first 5 factors are essentially the medical factors that impact the general development of communication and feeding. And the bottom 3 are your developmental issues that are seen in all 3 types of ASXL diagnoses in children. And we will talk about the impact of these top 5 medical issues on the development. So the low muscle tone and the muscle weakness, it plays a role in how our body is able to breathe and support itself in an upright sitting position. And so diaphragm is the muscle of breathing, allows us to breathe for speech and breathe for swallowing purposes, and having that low muscle tone impacts your ability to have a breath support. And so children who have low muscle tone tend to have issues with reflux. Your trunk muscles support your digestive tract, and the functioning of your respiratory system affects your digestive tract moves to some degree. And so the low muscle tone impacts the movement of food through the digestive tract and your breathing, and you will see eating, swallowing, as well as your verbal language and communication skills. The oral structures and the limitations associated with that. So having functional oral structures, it's important for you to be able to eat and talk. And so cleft lip and palate, having a smaller jaw or having a high palate can change how the movement of your tongue and jaw and your mouth is during the process of chewing or drinking or when communicating. And so the structural limitations impact your ability to eat or drink or talk. Also, the surgical interventions that happen in the mouth area changes how the sensations of the mouth work during the process of eating. And so those are also important considerations when we are looking at a child who has had a lot of surgical intervention. Sleep apnea, a lot of our children with ASXL struggle with sleep apnea. It's the quality of your sleep. If you don't get a good quality restful sleep, then it affects your ability to regulate your body during your awake hours and your availability to be able to learn from your environment. And so sleep apnea does impact the child's availability for learning from the environment. The reflux and constipation, these are again common medical conditions experienced by all of our children, and the movement of food through the digestive tract is very important in how our mouth moves for manipulation of different food textures, our desire to eat, our relationship with food, the enjoyment that we feel post feeding. All of these are impacted by how food moves through our digestive tract. And so oftentimes children experiencing reflux and or constipation will have altered experiences and thus altered relationship with food. The vision impairment, to look at the vision impairment, it's not just, does my child see far or near? The vision is typically looked at as something in four quadrants. So if you draw a circle, you have right, top, right, left, or top, right, top, left, and then bottom right, bottom left. And how we see an image is impacted by the quality of vision and equality of vision in all those four quadrants. And if your child does not have that symmetrical vision, oftentimes you'll see your child tilted on their head is tilted to one side so that they can get a functional image of what they are seeing in the environment. And that changes your body's awareness of where your body is in space. And so the vision impairment also, besides impacting feeding and swallowing, can also impact your communication skills in a large way. Social deficits, the speech impairments, difficulty coordinating mouth movements, comprehension skills, and then the ability to express verbally. Again, you see all of these developmental deficits of varying degrees in children diagnosed with ASXL.
So who's on your multidisciplinary team? This is just a snapshot. You may have many people part of your team. And the biggest part, of course, is you and your child. You are big medical decision makers. All of your team, maybe medical professionals, but you yourself is one of the biggest advocates for your child's care. So I always like to point out your role that you play in your child's therapy and development. We tend to think of your pediatrician as kind of your starting point, who may make referrals out. They'll take care of your child's needs on a regular basis. And then your nutritionist as well, depending on how your child is receiving nutrition. As speech therapists, we work very closely with nutritionists when we're going through assessment and intervention for feeding disorders, because we need to make sure that while we're managing your oral skills progression, we're also making sure that your child is getting adequate nutrition so that they can continue to grow and develop and continue to make progress in all these areas. And then your therapist, you may have a variety of therapists. In our geographic area, the speech therapists tend to be the ones who are your go-to for feeding and swallowing intervention. Occupational therapists may specialize in feeding as well. And we are probably the people you'll see most often, 1 to 2 times a week, if not more. So really, your therapists are who you're building relationships with, and we try to be not only a support in development and progression of skills, but a support for you in reaching out to other providers as necessary. And then your specialist, again, that's going to vary just depending on your child's needs. At our office, we work very closely with GI specialists because we see a lot of co-occurrences, especially with children who have feeding and swallowing disorders and also need GI management. It may also do ENT, neurology, endocrinologist, and cardiologist, but we would work with those professionals and you as a team to make sure that our plan is collaborative and we're not just targeting one piece, but we're all working together to help all of your child's skills kind of work together. So our role as a speech language pathologist, we do obviously address speech and language development, But like I said, at least in our geographic area, we are the professionals who assess the structure and the function and the safety of swallow. So that can be right from infancy and then through adolescence and adulthood as well. We work with families and children to help create treatment plans along with collaboration of the other providers so that we can develop the skills necessary to eat independently as much as possible. And we know kind of our limitations there. Like I said, we're with you a lot. So we try to help support your individual needs related to feeding, swallowing, and meal times, and recognize when we need to bring other professionals on board as well, because we do target just, this small portion, and there's so much more that goes into the development of your child's feeding skills.
We're going to look at the feeding skills assessment. So what do we really do when we evaluate somebody's feeding skills? Um, we we look at the medical history, and that medical history it's a very important step in the part of the assessment, because this allows us to determine what are the factors that we cannot change, and where do we need to have compensatory strategies to be utilized, and then where can we look at in terms of improving the function based on what's going on with the child medically. Um, and then that history just kind of sets the stage for us to kind of go through the next steps of our feeding assessment. Posture and positioning. And sometimes parents ask me, why is it so important? Why do you guys keep talking about the posture and positioning? We can stand and eat, lay down and eat, we can do all kinds of things, but the posture and positioning is critical for our children, particularly when they have low muscle tone or muscle weakness, breathing issues. And for that purpose, the posture and positioning matters, because breathing and holding our head upright is our body's priorities. And when fatigue plays a role in holding your body upright, your brain doesn't have a whole lot of capacity left to focus on the coordination of the mouth movements, which is needed for being able to eat successfully. And that's why having a stable chair that allows your body supported in the event that you are tired or fatigued allows the brain to focus on the movement of the mouth or oral coordination, then supporting your body to stay upright. So we do look at that posture and positioning to determine if a support is needed in that area. The next thing we observe is the oral skills, and our mouth moves differently when we drink and when we eat, whether we are drinking from a straw or a cup, or whether we are eating from a spoon versus biting into a piece of chicken. Our lips, our tongue, our jaw, and our cheeks have to do a coordinated dance to manipulate that food in the mouth so that it can be safely swallowed. And so looking at those oral skills and observing the child eat a variety of different foods allow us to determine how the mouth moves and what we need to do to make changes for improving the function. That leads us into the next aspect of our assessment, which is the swallow safety. The swallowing is a exclusive function with breathing. So you can either breathe or you can swallow. You can't do both activities at the same time. And so by observing a child eat, you can look for signs and symptoms where the food may not be going down the food tube and may be compromising and entering your airway. So some of those signs we look for is the coughing, choking, wet quality to the voice, yawning, falling asleep if a baby or a child is younger, and then of course hiccups and some of those sometimes minor signs like grimacing, blinking eyes. So we are trained to observe the child to determine if your child is able to swallow safely or not. And when there are concerns about the swallow safety, that is when we get into the instrumental evaluation. And so the most common ones that most of you probably are familiar with includes the VFSS, that is your video fluoroscopy swallow study. And then the less commonly used is the FEES, which is the fiber optic endoscopic evaluation of swallow. The difference between two is the VFSS is it's a live real-time x-ray of you eating, which allows you to observe the food movements in the mouth, how the food goes through the back of your throat, and how it enters into your food tube or your esophagus by maintaining the closed airway. And so you can observe the child eat and drink, and it lasts for anywhere between 1 to 3 minutes, and you are able to get a real-time picture. The fees, on the other hand, it's a little flexible tube which has a camera attached to it. The tube gets inserted through your nose, and then you get a bird's eye view of the food moving down from the back of your throat into your food tube. So fees is not commonly used because children are really afraid, and having something hanging in the back of your nose and trying to eat at the same time, it just not, doesn't happen with most of our young children. So we tend to use fees more with infants under the age of 6 months, or we will use it with our older individuals where we are really trying to look at that airway assessment. So the next slide, we're going to watch a video swallow study. Swallow, it is an animation video that just shows you how the food moves from the mouth into your esophagus. And so that video will give you an idea what we see on the video swallow study during the assessment.
Swallowing occurs in two stages, the oropharyngeal and esophageal stages. At the start of a swallow, a food bolus is voluntarily pressed by the tongue up against the roof of the mouth and backwards towards the pharynx. In response to activation of pharyngeal pressure receptors, the swallowing center in the medulla initiates reflexes that prevent food entry into respiratory passageways. The uvula contracts, which blocks the nasal passages from the pharynx. The laryngeal muscles contract, closing the glottis at the top of the trachea by tightly aligning the vocal folds. The epiglottis swings down upon the closed glottis. With all airways blocked off, respiration is temporarily inhibited. As the upper esophageal sphincter relaxes, pharyngeal contractions drive the bolus into the esophagus. The oropharyngeal stage is done and breathing resumes. During the esophageal stage, a primary wave of peristalsis initiated by the swallowing center pushes the bolus through the esophagus. As the bolus travels through the esophagus, the lower esophageal sphincter relaxes, allowing the food to enter the stomach. If the bolus is sticky and adheres to the esophagus, secondary peristaltic waves triggered by the intrinsic plexus at the point of distension completely clear the esophageal lumen to finish the swallow.
So that's just an overview of what we're looking at. As speech therapists, we're looking more at those oral and pharyngeal phases. So your mouth and your throat and your child's ability to protect their lungs from food going into lungs, making sure that their food goes to their stomach. So when we do a video swallow, that's the primary purpose, is so we can assess how safe your child is to take food by mouth. And like I said previously, we may do that multiple times throughout your intervention, so that we can continuously assess that safety, and it helps to guide our feeding intervention, because we need to know what is safe so that we know where to start, and then we can work towards getting our child safer to eat foods by mouth. So typically in a feeding intervention, we would address all of these factors with that knowledge of your child's safety through taking food by mouth. We look at positioning to maximize safety and efficiency, like Smitha was talking about. So in a feeding session, we are trying to find your child's best positioning and strategies that we need to use for positioning so that you can implement those at home. We would start with some oral sensory stimulation. Sometimes for the kids, we'll call these like mouth warm-ups, just kind of depending on your child's needs. Then we would look at oral skills facilitation. So that's looking at open cup drinking, safely moving the food around in the mouth, safely swallowing the food and initiating a swallow, and then looking at the amount of residue that may or may not be left in your child's mouth if they're taking foods by mouth. And there are some different tools that I'll have Smita go over that we can use to help with building those oral skills. When we're at a place where we're taking foods mostly by mouth, we can work on food texture progressions, progressing taste, making sure that we're working with your nutritionist so that we're making sure that your child is getting the nutrition by mouth that they need while safely managing all those textures. So there are some different ways that we do that, working on volume of intake as well. And then the main part would be to set mealtime expectations so that you can have some of these feeding experiences at home too. And that's what a feeding session should look like, is a little snippet of us working on strategies and working with you so that we can establish a goal to get to for feeding at home.
So we're going to talk about some environmental based and tool based interventions. So there are three main things in this area. One is the environmental modifications, which is some children function better in an environment that is quiet with minimal distractions, and they're able to focus better on their meal times, and you're going to have better mealtime experience for that child. And so making that type of modification to accommodate the child's regulatory need can improve your feeding. The second component is for those children who experience heightened anxiety associated with food and meal times, using a structured distraction for the meal time that allows the child coping mechanism. So and a lot of times, when we think about eating, most common recommendations are remove all the distractions. The child should be focused on eating. But our children who experience higher anxiety with meal times, having them given a coping mechanism, so having an interactive toy that they're able to use back and forth in between bites, sometimes can be a really powerful tool that'll improve the feeding experience for the child and the outcome. And so those are our main environmental modification. The second component is your positioning. So the positioning chairs are determined in conjunction with a physical therapist. So depending upon the child's muscle tone, muscle weakness, and postural limitations, we as feeding therapists, we provide input primarily in the area of having the upright head positioning, supported shoulders and head. And then the physical therapist really looks at over the years, next 2 to 4 years, what are the changes that are expected to occur in the body, and the accommodations that are needed for that positioning. So those are your chairs. And then the tools. I brought a few tools with me to share that you may see being used in therapy. And then, so some of these are, so here is a cutout nosy cup. When we work with children on learning to drink from an open cup, we use this cutout nosy cup. And if you notice, the rim of the cup is thin and it does have a cutout. So when a child is able to approximate their lips on the edge of the cup and you're able to tip the cup, this cutout portion allows to accommodate for the nose. And so when you lay the cup on the child's lips, that pressure cue allows the child to keep the lower lip supporting the cup. And then the tipping action would allow the caregiver to control the flow. And then you can teach the slurping action. You need that slurping action to be able to drink from an open cup, just like you need to have the slurping action to be able to drink from a straw as well as eat a spoon. So that's one of the cups that we use. The other tool that we use is a honey bear cup, and I forgot my honey bear cup at the office. Essentially what it is it's if you think about a ketchup bottle at the restaurants, the cheap $1 ketchup bottle, if you insert a disposable straw through the top of that bottle, and when you squeeze the bottle, it allows you to push the liquid up in the straw, and you use that mechanism to teach a child to suckle from a straw. And so that's the honey bear cup that we use frequently. We use different types of spoons, and this is one of the spoons that I actually like. We call it a textured spoon, and there's a lot of these different ones, versions of these that are available on Amazon or different online platforms. And the purpose of these textured bottom, the little spikes that you see, is it's the dentist chair principle. When you move something in the mouth, your tongue follows the tool. And so you use this spoon to teach the tongue to flatten. So when you're teaching the children to eat purees or lumpy foods, you use this spoon to cue the tongue so you can facilitate the tongue movements through touch. And so they come in different sizes. And so this is a hard textured spoon. You can also get the flexible textured spoons for young babies who are just learning to eat with a spoon. The other tool that we use very frequently is a Nook brush, and I'm sure a lot of you are familiar with this. So a Nook brush sometimes gets mistaken as a chewy tube, which it is not. And the top of the Nook brush is fairly soft. So if your child does chewing for seeking the oral input, then this is exactly what you do not want going into your child's mouth, because children can chew through the top of this brush and it can break and separate pieces into your mouth. So that's a safety concern. So never use Nook brush as a chewy tube, because it's not. And the way we use Nook brush is to really take it into the cheek area, so that a lot of the gagging issues that happen in children happen because the tongue thrusts forward and is not doing the side to side movements in the mouth. And so when you roll the Nook brush into the cheek area, you are stroking the edges of the tongue to facilitate the movement of the tongue from side to side. And we use this to teach the movement of the food from side to side, because the bigger chewing occurs in your molar region. So that's another tool that we use. The chewy tube, they come in different shapes, sizes, thicknesses, hardnesses. So depending upon the age of the child, we use these. And then most of them either like come in the shape of T or P and Q, and there's all kinds of things available there. And you use these sometimes for children who need the input and who are orally seeking. So they can use that as a safe way to get that oral input instead of mouthing non-food objects that are unsafe. So you will see a lot of these chewy tubes. We use these for teaching chewing, but we also use these for the purpose of oral seeking, that when children need that input. And the last one I have is a little mesh feeder. A lot of these are available and they come in different shapes, and now they have the silicone ones as well. So when you are teaching a child to chew, or the child who does not have ability to eat solids, or for a baby who is just getting into the chewing skill development, you can put pieces of food in this, and then it allows the child to safely explore the food and learn to chew. So these are some of our tools.
And typically we're using those tools in combination with our texture progressions and working on food repertoire expansion, depending on what the goal of that is, right? So we help to support in liquid modifications so that your child gets practice. If we do find that there's pharyngeal difficulties and that your child is not adequately protecting their airway, we'll oftentimes recommend thickened liquids if they're able to demonstrate safety. There are several different ratings of thickened liquids. So the goal would be to move from the thicker liquid to the thinner liquid as much as your child can handle. So we support in that with some of these tools. So teaching oral control so that your child is learning to maintain thinner liquids while protecting the airway. We work on that transition from liquid to smooth purees, to lumpy purees, then to mashable foods, and then harder to chew foods, making sure that your child is chewing adequately, and initiating a swallow, and clearing their oral cavity of all the residue. We might use some taste and texture pairings if your child has very restrictive taste preferences. It kind of just depends what stage you are in the feeding therapy process. It's very individual for each child, and we just meet you and your child where you are. And the goal is always to progress to the next space. But like I said, that is so individual. So we meet you where you are and move from there with these texture progressions and food repertoire expansions.
It's lunchtime. Make sure to drink water.
I am so sorry. That was my Alexa. I cannot get her to stop giving me reminders throughout the day. And then again, we're going to go back and spend a little bit of time at the end of our talk here on just kind of maintaining mealtime routines and managing feeding behaviors. And like Smitha touched on a little bit, some of our children might be anxious about doing new foods. Some might have their preference for foods, but we always have to start at a place of regulation. So our primary goal when going into any learning experience is regulation, and feeding behaviors. And we use behaviors to talk about things maybe we don't necessarily want to see, but a behavior is just a response to regulation. So we have to start there, and that's why our sessions look like mini meal times. So we'll collaborate with other professionals. Occupational therapists are always a great help and kind of our go-to for regulation strategies. We'll set a routine that works for your family, and that might not look the same from day to day. It might not look the same for every family. It all is going to vary. So that's where you get into that really individualized type of feeding therapy and care. We'll teach you to manage responses to the feeding behaviors as we are learning how to manage the responses too, because your children may respond to different regulatory techniques, and that may change throughout their development as well. So we have to constantly be changing our responses to help co-regulate so that we can teach them to get to the point of self-regulation. And then I think it's always important just to talk about the balancing of therapeutic meal times with your daily routines, because once you learn therapy techniques, you'll want to incorporate them as much as possible, but you have to balance that with doing your daily life. Therapy is done in typically a one-on-one or two-on-one environment with more adults available to support your child. And that's not typically how meal times happen, right? So they might be happening in restaurants, they may be happening with siblings, they may be happening in crowded lunchrooms. So it's not always possible to incorporate a therapeutic mealtime. So we talk with you about how to balance when to do it, and when it's going to be most effective to implement some of the therapy techniques.
So we're going to talk a little bit about the factors that impact feeding and meal times. And you know, when we are looking at each individual meal at home, and these factors for therapeutic meal in therapy as well, but success of a meal at home is impacted by several different factors. And these are some of the factors. So your emotions and your regulation, you know, your child may be tired. overstimulated, sleepy, sick, and that's going to change their ability to regulate themselves. Some of the other factors is, you just have had a vomiting experience. It's going to change how you're able to approach the food after having that vomiting experience. There may be a constipation going on and your child hasn't had a bowel movement in 3 days. It is going to impact how they approach food and their meals and their emotion towards the food at the time. Congestion. If you are dealing with the allergy season, that's the season where we see the highest number of children coming in with picky eating that was just recently started. So all of these factors impact your child's ability to regulate themselves and be how they feel towards food and will impact your mealtime. Feeding approaches, there is a lot of information that gets thrown at all of us as parents, like, oh, baby-led weaning, we all have to do that. Like, that's the thing, that's the right way to introduce foods. Or, no, we are going to do SOS, we are going to do this or that. And so the food approaches, feeding approaches, whether you do a structured or unstructured, impacts the outcome of your meal at any given time. The caregiver expectation is the next one. All of us as parents, we're not just looking at therapy or feeding therapy or looking at meals through the therapeutic lens. Our focus may be completely different. Like, we have to pick up our other child and we have only 20 minutes and you have to get, so much food into your child. Or you may be getting questions from your pediatrician that, oh, we haven't gained enough weight, we need to get enough food in them. Or, oh my gosh, we are dehydrated, we are not pooping, we have to have 12 ounces of fluids in our child. So our expectations of a mealtime changes depending upon what's going on. And that expectation can change what that meal looks like. Sometimes we want to just do meal in a 20 minutes and the volume is no bar. Or sometimes, we want to focus on, oh my gosh, please eat, but I do not want to wipe the walls and the floor at the end of your meal. So you're focused on getting the child to really have that socially appropriate behavior in that mealtime, but that's going to change the outcome. Parent-child interactions. This is like, you get this a lot. As a mom or dad, sometimes you get the short end of the stick, which means your child eats better with the babysitter, and that's a dagger. You are taking care of them. You are doing everything for them. And there comes some new babysitter and comes in and your child has awesome meal with them. And so when you look at all these factors, the parent-child interaction or the caregiver-child interaction, children change how they behave and interact with different individuals. And sometimes when you have that babysitter or grandparent or aunt with whom the child eats better, I would say take that, because instead you have the whole child and you are their security blanket. So sometimes if the meal goes well with another person, I would actually pass that responsibility on and give yourself a respite for that meal without feeling guilty, because it's not your fault. Your child relies on you. You are their security blanket. And so you're likely to get more of difficult behaviors or resistance or whatnot from a child in a mealtime. So those interaction factors do play a role in how the meals happen. And then the last thing is the impact of deficits on social interactions. Communication deficits are big, and that is what leads to social interactions that are either acceptable or not acceptable. So in terms of a community expectation. And so a tantrum is communicating something. We as caregivers or parents may not be able to be in the state to interpret that communication in the given moment. But the social aspects of feeding can be impacted just based on the communication limitations. And so when you look at a child's meal and when you analyze and you go, oh my gosh, he had a great meal or he didn't have a great meal, there are all these components that are happening that'll give you whether it is a successful meal or not.
And that just kind of leads us into this very, very broad kind of hierarchy of when to take on implementing therapeutic meal times when you're doing feeding at home. So our nutrition and safety needs always come first for both your child and yourself. If the child's body is not feeling safe, if their nutrition needs are not being met, then we might not be in the right place to work on some of those more fine oral motor skills. So this is when we look at G-tube as a positive type of thing, right? So it gives you a way for your child to have the nutrition, and we can still work on improving oral skills even with G-tube feeds, right? And it can sometimes take the pressure off of, oh, I have to get this amount into my child by mouth, right? So once our nutrition and safety needs are met, then we can look at those psychosocial factors we talked about. So my child's response to engagement in the mealtime, am I ready to engage in this mealtime? Where are we, and what type of level of support am I able to provide for my child at this moment? And then if all of that kind of checks your boxes, you feel good, your child feels good, then you can move into doing some more of that direct therapeutic work that you may have been working on in your intervention sessions. And I just like to point out that all meals are beneficial, right? Kids learn to regulate during meal times. They learn to eat when they're actually eating. So even if you don't get to, oh, I used my Nook brush like my therapist taught me, that doesn't mean that you weren't providing therapeutic support for your child in that moment. And you have to balance, again, being caregiver and being your child's therapist. And so we just have to take that, I think, really meal by meal and day by day, and look at, like Smitha said, the social surroundings of what's going on before we implement that. And then these are just some references and resources. So most of the information that we talked about today can be found on ASH's website. That's the American Speech Language Hearing Association. They have a feeding portal, and it's just a quick reference. And then Smitha recommended as well, Feeding Matters. I think there are a lot of good parent resources there. They do feeding conferences. So these are just some places that we've found to be helpful that we use in our own practice, and that are parent friendly as well.
And the feeding matters, just to add another quick thing about that is it has a parent support program or parent buddy program where you will be paired with another parent who has gone through similar type of challenges. They will find parents and pair them up from the similar region. They have one of the best parent resources as far as quick access, and then having a human support instead of, you just kind of left on your own to look through the website. So I really love what the Feeding Matters have in terms of the resources and support systems.
And that is all we have for you. So we're open to questions.
I do see a question in the chat. Steph, did you see that one?
No, I'm just full presentation, so I can just see your faces.
Yes. It's from Megan. She said, have you worked with children who are detached at the corner of their mouths?
So I have worked with multiple children with different types of structural limitations. So I'm not sure if you're talking about facial cleft or you're talking about the sagging of the lines where you really have that low muscle tone where you're not able to get more of those upper lip movements. But, I've seen children with facial clefts where, a portion of the mouth is not formed and the cheek muscles are not fully developed. So there is a disruption. So there is sort of like an opening, if you will, on one or both sides, just like your cleft lip or cleft palate. And there are surgical interventions that come at a little bit of a later time. depending upon what level the child is in the growth phase of. And then which muscles are really involved in that structural limitation. I've also worked with children where they have surgical interventions where part of their jaw was removed, or part of their gums were removed, or part of their tongue was removed. So you have limited oral structures available. And regardless what the limitation of the structure is, there are always compensatory mechanisms. And our human body is so beautifully designed that it may not look pretty, but it is able to accomplish function. And so I have seen like pretty remarkably limited oral structures, and the child is able to eat all the different food textures despite those limitations. So it varies child by child. I see what you're saying. So when you get the lip closure, there is probably gaps on the side. Does that cause leaking of the food or the fluids from the edges, or is it just the accumulation of food in that area of the fissure?
Megan, you're muted. We can't hear you.
I'm sorry. I leave it muted until I have permission because then I end up talking over. I apologize. Thank you. I haven't seen a lot of others that have this, but so when she opens her mouth, the spot right here where the lip would come together when you smile, where it's just kind of I don't want to relate it to a horse, but anybody who's familiar with horses, there's a gap right there. Yeah. So it kind of comes in and then pockets because it doesn't attach. It's almost like there's a missing component there. Yeah. So it's right on the lip structure. I didn't, because she does have speech delays and she did have some chewing issue with the hypotonia. Yeah. That muscle attachment right here with the face going straight down up through the ear. I wasn't sure if this missing component is making it difficult for her to utilize that efficiency in her jaw movement. I wasn't sure if there was something in it because she has trouble bringing her lips forward as well. And I was wondering if you'd seen anything similar. So she doesn't tend to drip food, but she also does not produce a lot of saliva either. Her hydration issue is something I have to keep tabs on. So I apologize. Thank you.
So depending upon what's going on, so what occurs is your cheek muscles are formulated in such a way, so your lip movements, front, back, opening, close, they're dictated by those muscles of your cheek. They're also dictated by the muscles that sit above your lip and the muscles on your chin. And so it's a combination of muscles that control your ability to pucker your lips, to spread your lips, to do the slurping action. And so you also, the muscle movements of the cheek applies pressure to your salivary glands. So you have salivary glands across in your mouth. And so when you do, where you apply pressure, if you just do that, you can feel the saliva squirting towards the bottom of your mouth. So the pressure of the cheek muscles play a role in the generation of saliva, in addition to the smell and the movement of the mouth. And so knowing that there is a limitation of that, if pocketing is an issue, and I'm not sure how much tongue function because of the muscle formation, but a lot of times you can use compensatory strategies, by using a lot of touch stimulation to create the sensory awareness. That's the number one thing to attempt. The second thing is to provide a tactile cue to that fissured area to facilitate as much of this type of cheek contraction. So that's again a sensory strategy. The third thing is to have the teaching, like creating awareness, and then we do the mouth check. I mean, you can call it mouth check, cheek check, we can kind of come up with terms, and then using the tongue tip to use every 2 to 3 bites clear up that bolus. So there are multiple sensory strategies you can use to address the pocketing or pulling of the food that might be happening during chewing. And then you can also teach compensation by placing the food towards the back and then chewing by focusing the food on the back and preventing the food from coming in the front. So sometimes I teach my kids, we chew on one side and you swallow from the cheek instead of normal chewing patterns where you chew, chew, transfer, chew, chew, bring the food in the middle of the mouth and then swallow. So you create a compensatory pattern where you just do smaller bites, more intensely flavored food. So you have awareness of it. Chew, 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 swallow. So you don't go into the transfer of the food. And sometimes that can decrease how much pocketing there is in that anterior portion. And all of these strategies, all of them may or may not work, but if we worked at it texture by texture, you will see some functional changes to compensate for those fissures.
No, I appreciate that because it's been an interesting learning experience because not a lot of people have seen that. And some people don't understand what I'm trying to convey, everything involved with the kids. But she also had a posterior tongue tie, which we had to get, but she didn't get that done until much older because they kept missing it.
Yeah.
And she's always been really good about eating. She did have an elongated epiglottis that went in, but it's receded since then. But she does get fatigued when she's chewing, you know, so she wants to eat quickly. So we have to slow her down, you know, thankfully she's not too picky, but she does get fatigued. Like she doesn't want to chew steaks because it requires too much effort. And then of course there's that swallow risk. So I was just wondering about how to, because of course her posture is a thing too, we're working on that, but trying to help her engage more of her mouth, especially her tongue, trying to get her to manipulate that more. You know, I was just wondering if there was an association here that you may know about, because it seems odd when I ask people, but it seems relevant with her being able to manipulate her mouth. So
I would say a lot of touch stimuli in that region, lot of mouth work by really invoking the tactile stimulation.
okay.
It's what's going to help with the functionality of what's happening. And one additional strategy that you can use when you have that fatigue component involved is you rotate the bites of textures. So, like for example, if she's eating steak, like, you know, you have a smaller bite of steak, bite placement cue, place it to the posterior, number of chews determined by your therapist, and then the swallow, and then the next bite of something that is lumpy and slippery. For example, a bite of condensed soup, post bite of steak will gather up the bolus together and take the bits down, and you have less partially chewed bits left in the mouth that she may not be able to gather. And then rotating the bites of those textures, you can get a better volume of intake. Plus, you can have her enjoy the piece of steak if she particularly enjoys it without causing her to fatigue. So even not like a huge piece of steak, you may get functionally several bites of steak. And once she realizes this, how the compensation works, she may be able to do more to be able to get more steak down.
Yeah, because you know, I've thought about digestibility, you know, with the motility of the stomach itself as a muscle. So you have that mechanical digestion and heavier things that are hard for the kids to chew. That's part of I want, you know, that's why I wanted to ask. So it's just, I appreciate that. Thank you.
And then ladies, Juan has raised his hand and has a question. Go ahead, Juan.
Hi, good morning. Thank you guys for doing all this. This has been very, very helpful. I do have a concern. So my daughter right now, she is 5 months and a few days. And she's still in the hospital. She was discharged for a little bit, and 4 days later, she was reinstated in the hospital, and she's been there for a week again. And for some UTI and things like that. But my main concern at this point, she's been having issues with her with the respiratory, with the breathings, but that has been kind of addressed already. But the main problem is the feeding now. She being 5.5 months, she it's she got to the point where she's not tolerating any feed. She has a GI tube and in a trach, but through the GI tube, she is not tolerating anything. We've done from Pedialyte, we've done from only breast milk to Elecare, 45 Elecare, and but she really doesn't tolerate anything. You know, as soon as a drop of food goes into her stomach, she starts vomiting, and the vomitings are very, very constant. So I don't know what can we do and what can we suggest the medical team to to do. What are the plans with kids with this condition?
One of the things that you can try, so sometimes when the G-tube feeds are not tolerated, depending upon the placement of the tube, if it is rubbing against the lumen of the stomach in a certain way, it can cause that vomiting sensation. Is your baby able to suckle on a pacifier?
No.
So does she have that? So during the first, when the baby is born, they're born to be able to suckle spontaneously. It's reflexive. So
Right.
kind of like, when somebody brings a finger close to your eye,
Right.
you blink. And so that reflexive suckle should be maintained in the event that a baby's not going to be able to feed orally. So at 5 months, most of that reflexive suckling starts to translate into a learned or a functional suckling from bottle or from breast. So
Okay.
one of the things that can help is if you're able to get suckling going on a or even on your gloved finger, that suckling can transfer and lead to peristaltic movement into the esophagus because your body
Right.
begins to swallow the saliva. And those peristaltic movements can be helpful in reducing some of the retroflow of the food coming up into the stomach. Because when the esophageal walls start to move and push the food down into the stomach, that reduces some of that retroflow. So that's one of the strategies to try and have the suckling going on a pacifier before you initiate the tube feeds.
Okay.
The second strategy to try would be to have your baby laying on the left side of her body. So the way our stomach sits in our body, it's sort of like, imagine, here I'm going to use something that I have. So a bowl. So like imagine, your stomach sitting like this. And then if you lay the baby down on the left side, now do you see how the bowl where the food can sit at the bottom of the bowl instead of being at this sort of like
Right.
angle? And
Mhm.
so I would have the baby lay on the left side of her body. I mean, she's 5 months old, so you're going to have to kind of position her in
Right.
that left side lying and then get her to calm down and comforted where her body is flexed and not like arching or flexing. And then
Right.
once she gets into that left side lying position, I would slowly start doing a drip feed through the tube. And what that does is, because the stomach angles like in a bowl shape, you may be able to get a very slow drip going in the beginning. And then that'll help prevent the retroflow because the food will stay on the bottom of the stomach instead of flowing backwards up. So that's a second strategy that you can try to see if you can decrease some of the vomiting that's happening.
Okay.
And the third strategy is, if she has a tube in her stomach and not a NG tube going from the nose, is to try some thickened feeds. And then, you will have to see, depending upon when she was born and if she wasn't premature, you could
She
use
was,
gel
yeah,
mix.
she was premature. She was
She
about
was
4 weeks premature.
4 weeks premature. So, so she's kind of like in that borderline zone where 4 weeks is not tremendously premature,
Right.
but talk to your doctors. And since she's 5 months old at this point, see if there is a way to try thickening using either gel mix or food-based thickening. And so the theory behind this is heavier the food, it keeps it down, and it prevents the food from shooting up in your esophagus, leading to vomiting. So
Right.
typically when we do the thickening of the food, I use, you can use, if you use gel mix, then I would use the thickening recipe on the gel mix container and then do a slow drip of the food through the G tube and see if the thickening helps cut some of that nausea. So these are the three things that I would try without me really seeing or knowing much about your baby.
Right. And also she got diagnosed with duodenum inversum or duodenum inversum.
And
So the the duodenum, it's or duodenum, it's instead of looping down, hers loops up and comes down.
oh, so it looks like she probably is dealing with a lot of motility issues. So based
Yes.
on what you are describing, to me it sounds like the emptying of the stomach can be a really big component in terms of, like, your stomach typically empties into your duodenum in somewhere between 30 minutes to 2 hours. But
Wow.
when you have the duodenum that is wrongfully angled, then
Hmm.
it may impact how quickly your stomach empties into the duodenum. Typically, they will use medications. So, like, for example, cyproheptadine is one of the medication that they use for facilitating gastric emptying. And so, there may be a combination of positioning and medical management that may have to work together, sounding, based on the medical issues that you're describing with your baby.
Yeah, so we are right. I recommended many times about this medicine. Um, I'm actually having problems with the medical team because they want to address this issue as if it's something normal that, pause the feeds, interchange the feeds, and it will eventually get better. But it's been a week of not eating, and the only thing she's being treated with, it's omeprazole and sodium bicarbonate. That's the
Okay.
only thing she's given at nighttime to kind of make her GI move a little, her motility move a little faster. So I don't know if that's
I have a couple of articles that I can share with Sarah that are on cyproheptadine and the use of cyproheptadine with younger babies. I can
perfect.
share those, and if you want to share those with your medical team. Now,
Yes,
again, you have to understand I'm a therapist, and my
right.
experience of using all these medications is my work done with the GIs and the neonatologists and other people. But cyproheptadine has shown to calm some of the digestive tract, and it facilitates in gastric emptying. A
Hmm.
lot of GIs, depending upon what philosophy they practice, some of them are very apprehensive and will not use cyproheptadine with younger babies. And I
Right.
have worked with GIs like that where they'll say, absolutely not. The baby's too little. We are not going to do cyproheptadine. And sometimes you may have to get a second opinion to find a GI. More younger GI population, they're more open to using cyproheptadine. But I have seen both of those. So I'm going to pull out those couple articles that I have that given to me by some of the GI or neonatologists
Okay.
that I will share with Sarah. And then, Sarah, if you don't mind forwarding those articles to Juan, then you can share that with your medical team. But again, you're kind of, at their mercy in terms of the contraindication and the use of the medication, because they have to feel comfortable enough to consider those medications.
Yes, unfortunately and fortunately enough, yeah, that's the case.
Also, another medication that have shown to have efficacy in some of our kids who have had a lot of like manipulation and surgical processes done in the abdominal area, and that's called gabapentin. And it's a medication that is used by neurologists. Typically, it's also used as one of the seizure medications. So when I share articles on cyproheptadine, I'll also share a couple of articles with gabapentin used in really young babies. So you can share those as well. It's used for like nerve pain and some of the vomiting issues with super young babies who are in the NICU or are in the hospital repeatedly. So you can use that information to see if you want to share those with your medical team and see if any of those will make a difference.
Absolutely. And actually, I requested we're having a meeting later today at 3 o'clock with the GI doctor, and hopefully the motility specialist will be joining us as well. This is a big thing for me at this point, because trying to get two specialists on the table, it's really tough.
Yeah. No, I hear you. As a parent, it really puts you in a very tricky position because you want to do everything you can, but to some degree you are, at the mercy of your team.
Okay. Right.
I know that slow gastric emptying, I have heard several parents talk about that symptom. I don't know off the top of my head if it's been named as a symptom as part of BOS. Have you read that?
I have not, no.
Okay, I'm gonna look into this a little bit more. I'm sorry, I don't know off the top of my head, but I have definitely heard other parents talk about slow gastric emptying, and I wonder if it'd be worth just putting it on the Facebook group as like just a shout out to see if anyone else's kids have struggled with this, and if anyone else has had success using these medications, especially with a young age, and maybe that would help the specialists to hear firsthand experience from other parents.
Okay.
It's worth a shot.
Right, absolutely. We'll do that.
Yeah. And then I'll make sure I send everything to you, especially before your meeting today. I hope that goes well.
Absolutely. All right, awesome. So I wrote everything down. So yeah, so I have some homework to do today. Yeah.
You're doing
Well,
great,
good luck, Juan.
Thank you very much. Thank you guys. You guys are amazing.
Thank you.
We are 15 minutes past our scheduled time, so I want to be respectful of Smitha and Stephanie's time. If Nora, I know that you're on the call, and I didn't know if you had any questions or anything you wanted to say before we sign off here. And feel free to put it in the chat if you're more comfortable. But while we're waiting for her response, oh, she says, not right now. Thank you. Well, Stephanie and Smitha, I just thank you so much for your time. And this session was just so helpful and full of so much information. I know that this is a really broad topic to speak on, but I just really appreciate you catering it to ASXL families specifically and addressing both the medical side of things, but the emotional and social pieces that come with feeding. I know that it's just a very full topic to speak on, and you both did so beautifully. So thank you so much for your time.
Thank you, Sarah.
All right.
Pleasure.
All right. Thank you so much.
Bye.
Bye-bye.